Hello, let's talk about Chapter 39, the lower digestive tract disorders. Now, please have your book with you so that we can go through the book together, and I'll have some pictures and figures and things like that for you to look, cultural considerations, things like that for you to peek at in your book. I'll also point those out if you don't have your book, but I'd like you to have it. So anyway, let's talk about BMI calculation. So the first part of Chapter 39 talks about obesity. And obesity is a lower digestive tract disorder because it does involve the stomach and intestine. So because it involves most of the intestine, it's going to fit into this category. So the term obesity is used when a person's body mass index, or BMI, is 30 kilograms per meter square or more. So I'm going to get into that a little bit more, but right now I want you to learn to calculate the BMI. This is going to be important to know that because you may be given a question about calculating a BMI. It won't be a difficult question because here's an example. So a patient weighs 305 pounds. So we need to convert our pounds to kilograms. And we know 1 kilogram is 2.2 pounds. And that is on this slide. And is this patient, go back up to the question, is 2 meters tall, or 80 inches. So to convert it to meters, it's meters squared, which is 2 with a little 2. And if you'll go down to number 2 on this slide, you'll see how it's taking the meters squared. So that's 2 meters tall, which is 2 meters squared. So again, a patient weighs 305 pounds and is 2 meters tall, or 80 inches. So they may give it to you in inches, but I doubt it. It's just for you to relatively realize what 2 meters is. So what is their BMI? So body mass index is calculated by dividing the weight into kilograms by height in meters squared. So that's the basic calculation. And that again is kilograms by height in meters squared. Anyone over a BMI of 30 is considered obese. So number 1 here is convert pounds to kilograms. And we know that 1 kilogram is 2.2 pounds. So 305 pounds is equal to 136.6 kilograms. So that's 305 divided by 2.2. So now take your 138.6 kilograms and divide it by 2 meters squared. And that really is 4. So 138.6 divided by 4 gives you 34.65. Now, if I didn't explain it clearly, or you need to just look at it a little bit more to understand it, it is in your book. It's also up here in the link, how to calculate BMI. So you can also calculate your own while you're at it. Okay, so I'm going to move on, but this is something you will need to know. So here's actually a BMI calculation chart. So if you want to see where you fit in, so let's look at your height over on the left. So I'm 5'5". Not going to tell you my weight, but you can see 5.5 there on the left. And then you would just follow it over and find your weight. And that would tell you what your BMI is. And if you notice that the green is healthy, blue is underweight, the yellow is overweight, orange is obese, and red is extremely or morbidly obese. Now, don't freak out if you fit into some sort of category that you don't like. I just want you to be a healthy nurse, so do what you have to do, okay? So we want to be healthy. We want to be good examples for our patients as well. So obesity. So you can have, if you are obese and you can't seem to lose weight. Now, people do have surgery for obesity. There's several types of surgery that I'm going to talk about. But before you have surgery, they will want to have you a mental evaluation. They want to be sure that you have someone that will be a good support system before surgery and after surgery. So you have to mentally be ready. You have to have somebody that's supportive. So you really need to prove to your doctor that you want to lose weight. So you may have to lose a few pounds even before you have the surgery, unless there's some medical indication where you need to lose the weight right away. So surgical intervention, if you'll look on figure 39.1 on page 743, you'll see the different types of surgery. So we've got the adjustable gastric banding up at the top, where they just kind of put a band around the stomach and make the stomach smaller. The sleeve banding, or the gastric sleeve, just makes the stomach smaller also. But you still have, notice you still have your small intestines attached there, so you still get all your digestive enzymes with those two particular surgeries. In the duodenal switch, there they actually sew off the pouch, the stomach, and there's some little twists and turns of the intestine. The jejunum is sewn into a different area. Food bypasses the small intestine, so you do get some more, you get more problems with these surgeries. So there's also something called a vagal stimulator, and that stimulates the vagus nerve. So the system consists of electrodes that are implanted via laparoscopy, which usually be through your belly button, above the juncture of the esophagus and stomach, so it goes into there. A regulator is implanted just beneath the skin. It can be turned on or off, recharged, programmed by an external device. Electrode blocks signals from the vagal nerve. Now, where does the vagal nerve get its signal from? Well, it gets it from the brain. So the hypothalamus can be involved in the cause of obesity because it helps manage hunger. So the hypothalamus is in charge of our hunger, as well as some of our hormones like ghrelin helps us be hungry. So those are some hormones that are released. Also, a brain tumor might be the cause of obesity. So let's go on down to, if you've had surgery, what kind of care do you get? Well, if you want to do a focused assessment. So what's their current state of health? Now, obviously, one of the most important things you want to do is weigh your patient and document the weight, the chronic illnesses, any other problems that they have, like cardiac, respiratory, or orthopedic problems. And they probably do have a lot of those problems related to obesity. So because of the obesity, their knees may hurt. They might have trouble breathing, right? Short of breath with exertion. So you want to document all of their complaints. We want to be sure that are they able to manage their self-care and management. Inquire about interpersonal relationships. And this is part of the pre-surgical type of assessment that should be done also. How do they cope? Now, you know, some people cope by eating, right? You get stressed out and you eat. My husband, for example, he's a mindless eater. He doesn't even know he's eating. He'll go to the refrigerator, open it up, be thinking about something. He's really smart. So he's thinking about something intensely, not realizing that he's also shoving potato chips or something that maybe isn't so good into his mouth. And it's kind of a mindless eating. It happened to me once too, when I was like I was overly tired, and I was working in the ICU, and I found myself, this is so weird, I found myself at the machine buying a Snickers candy bar before I even knew what was happening. Because my brain just kind of took over, that hypothalamus just said, you go eat something, and I just put the money in and ate a Snickers bar, and I looked at the wrapper and went, oh my goodness, what did I just do? So there is mindless eating or stress eating too. So we want to, the thing about bariatric surgery, which is what a person who is obese is going to a bariatric surgery center usually, they might have bariatric needs, a bigger bed. They might need a larger wheelchair. So wherever they go, they will need extra sized things. Maybe the gown, maybe the blood pressure cuff. So if you choose to work in an area like that, or even if you have a patient not even having surgery but is obese, be sure that you have that large blood pressure cuff. Let's not make a big deal about their weight, right? We don't want to make them feel self-conscious, but we do have things that we need to do medically to be sure it's done properly. And if you use a blood pressure cuff that doesn't fit the arm, you're not going to get an accurate blood pressure reading. So be sure you get a large cuff for your blood pressure. We want to monitor the patient's tolerance of physical activity. Are they tachycardic? Do they get tachycardia or tachypneic with exertion? And how can they tolerate activity? So adequate nutrition. So now this is post-op. Oh boy, where did I go? I went to the next page. Sorry. I was on the wrong focus. This says when I turned the page. Sorry. All right. So as I said, so the scale, also you might need a heavier scale. I know at some facilities, they even have like a scale that's in the floor to weigh larger patients. All right, and as the book says on page 744, it's essential to convey an attitude of respect and concern. Now let's go to interventions after the surgery, still on page 744. So the post-op assessment focus on oxygenation, always, right? We always focus on our oxygen. Maslow says so, our ABC say so. So oxygenation, we can check with an O2 saturation. Now if they've had surgery, they might not want to take deep breaths. So we need to encourage that, remind them. We want to check their skin integrity, because if they can't move around well in a bed, if the bed isn't big enough, they might get pressure type situation. Now, just because they're obese doesn't mean that they have poor circulation. In fact, they have less circulation in their fat tissue than someone who is thin. So that fat tissue can get injured. So we have to keep an eye on that. That's why we've got to be sure that they fit into the bed correctly. We want to check their prevention, their nutrition, and always prevention of DVT. How would we do that? How would we prevent a DVT? Well, there's a couple things we can do. We can have them flex and point their feet like they're riding a bike to keep that circulation going in their legs. They might have stockings. It might be a little difficult because they would be too tight. Also, there's a blow-up type of circulation. It blows up and retracts and constricts. And that we put that around their legs. Again, that might not fit. So you can flex and extend their feet. All right, be sure that you elevate their head of the bed, not too much, 30 degrees, 45 degrees at the most, because remember they've got a belly that may be resisting against a deep breath, so we don't want their lungs, we do want their lungs to expand. anesthesia has an affinity for adipose tissue. And what that means is that the drug may hang out in the adipose or fat tissue a little bit longer. So as the drug is gradually released from the tissue, it can prolong the sedative effects of the drug. If the patient's respirations are depressed, be sure he or she is positioned to maintain a patent airway. So then, after a few days, they should be able to get them up, which will help with their breathing. It will help with their DVT situation. If the patient normally uses a CPAP machine for breathing, which sometimes that goes along with obesity because they can't expand their lungs. Also, they might have a BiPAP machine, and they use that at home, and they might need it at the facility as well. So that potential for skin breakdown, remember the blood supply, as I was saying, to adipose tissue is relatively poor. So the healing is slow and pressure injuries develop more readily. And that includes the wound. The surgical site might not heal as quickly either. Also, because we learned about fungus growing in tissue folds, we want to be sure that this patient might have two folds touching, and we would have some yeast growing in that, or candidiasis. So we want to always keep their skin clean and dry. Inspect the wound for margins, intact margins. So because of the obesity and the movement, it may pull those stitches, and sometimes you might even see not just wire sutures, but they actually have a plastic around them, and they're more sturdy to hold a wound closed. They're a lot sturdier. Support the abdomen with a pillow for coughing and deep breathing. If you can't find an extra pillow, take a blanket, fold it up, tape it around, something to support their abdomen. And that potential for DVT, I'll just repeat, it's important because if they have a DVT, it can break off and go into a pulmonary emboli. Now we really got an oxygenation problem. So DVT can lead to a pulmonary emboli, so we want to really avoid that. Early ambulation will help. Position change, deep breathing, leg exercises, all helping that. I know that's a lot of information for the first couple pages of this chapter, isn't it? You're thinking, is it going to go like this forever? Maybe. So we want to encourage our patient to walk 3 to 4 times each day. And most bariatric facilities are equipped and designed for movement of obese patients, so they might have a larger doorways. I think there's one in Fresno. There's a bariatric surgery hospital, and that usually has a waiting list. So we want to be sure that they do have, be careful of inadequate nutrition. So the patient is advanced from water to clear liquids and then to full liquids. Now, look at this. Initially, the stomach or pouch will hold only 15 to 30 mLs. That's a little cup. So they start out small because, again, they've had their stomach size reduced. So they're not going to hold very much. So the pouch is small, and then they'll slowly start graduating. They'll slowly start adding fluids or soft foods. High in protein, low in fat and carbohydrates. Now, these people are going to have to learn to re-eat, not only to lose weight, but also because of the type of surgery they had. So we need to be really supportive of that. They'll need vitamins, multivitamin, calcium, vitamin B12. Now remember, B12 is absorbed in the stomach with the intrinsic factor. So we want to be sure they get enough vitamin B12. Dumping syndrome. Now we talked about that, I believe, a chapter or two ago. That's mentioned here also. dumping syndrome, which is described in chapter 37, is a common problem. The patient can learn to avoid it by selecting appropriate foods in the proper amount. And if you remember dumping syndrome, you get sweaty and, diarrhea. It's almost like you're hyperglycemic. It's the same kind of symptoms that a dumping syndrome is like that. Readiness for lifestyle changes. So they need to change their mindset. And this is part of that pre-surgical psychological training or learning that they have to do. They're going to help them avoid such negative thinking by focusing on their accomplishments. Look at you, you've gone through this big surgery, you've made some changes. For persons with a history of overeating, learning to eat small meals and avoiding favorite snack foods can be very stressful. Now, because their stomach has been reduced in size, they're not going to be able to eat like they used to, and they might start throwing up. Well, that could be a problem too, right? It's going to lead to vomiting and irritation of the esophagus, and they're not going to get their vitamins. So they need to learn to re-eat small amounts. And most bariatric centers have counselors to help patients with emotional adjustment to weight loss surgeries. And remember, as I've said before, nobody knows what it's like unless you've had it done. So another person who's had that surgery is a great support for a person undergoing weight loss surgery. So if you just look at the patient teaching box, post-bariatric surgery, diet high in protein, low in fat, carbs and roughage, divide your food into, here we go, 4 to 6 small meals. Doesn't that hold true for all the GI system and all the GI problems? Small feedings. Do not drink fluids with your meals. Well, that's kind of different because normally we do, but why wouldn't they? Well, because the fluid fills up the stomach. So we don't want to fill it up with water. We want to fill it up with some nutrition. Food high in sugar or fat may cause you to have diarrhea, acute diarrhea. Take dietary supplements. Weight loss is rapid in the first 6 to 12 months, and then it might slow down. They get to go shopping, buy new clothes. Must follow the prescribed diet to sustain and maintain the weight loss. You'd be surprised how many people that you don't even realize have had this surgery. It's a good thing for a lot of people, and it makes for a healthier person. All right, let's talk a little bit about malabsorption on page 745. So malabsorption is a term used to describe a condition in which one or more nutrients are not digested or absorbed. 2 examples of malabsorption are sprue, and there's a couple kinds of sprue, and that's celiac sprue because occurs in the celiac part of the bowel. And then there's lactase deficiency. There's also, when I'm talking about 2 types of celiac sprue, there's also a the traveling sprue that you get when you go to another country. So a common sign of malabsorption is steatorrhea. So that's a good word. That's the presence of excessive fat in the stool. Rhea, that R-R-H-E-A, rhea, it goes along with diarrhea, steatorrhea. So those are all very loose stools. One is fat, that's steatorrhea, fat in the stool. Stools are large, bulky, foamy, and foul-smelling. Patients may also have weight loss, fatigue, increased libido, easy bruising, edema, anemia, and bone pain. Why bone pain? They're losing their nutrients like calcium and vitamin D, so they might have bone pain. Sprue is treated with diet and drug therapy. Now, as I was mentioning the two types of sprue, it is listed on page 745. Celiac sprue is a genetic abnormality characterized by severe changes in intestinal mucosa. And then there's tropical sprue, caused by an infectious agent and results in malabsorption of fats, folic acid, and vitamin B12. So obviously, the treatment for each one of those would be a little different, right? Lactase deficiency, they do not have adequate lactase to metabolize lactose. So they're treated with eliminating milk and milk products from the diet. Now let's look at the cultural consideration there. What does culture have to do with malabsorption? Well, inherited lactase deficiency is most prevalent among African Americans, Asians, and South Americans. The dietitian should be contacted to help that patient design a culturally appropriate diet. So as I was saying, steatorrhea is a sign and symptom. We did talk about those. Bloating, cramping are also some signs. Diagnosis is usually made on lab studies, endoscopy. So if the doctor did an EGD or an endoscopic procedure, he might take a biopsy and see if there is, they'll take a biopsy, send it to the lab to see if it's diagnostic for sprue. Biopsy is always the best. Also, lactase deficiency is diagnosed on the basis of a history. So whether they can tolerate it or not, that's kind of like they probably know that they have that because of the signs and symptoms every time they drink milk. Almond milk, cashew milk, not going to be the same because we're talking about milk products. So that's coming from a cow. So, sprue is treated with diet and drug therapy. We talked about that. And lactase deficiency, eliminated milk products. Lactase enzyme can be mixed with milk or taken from drinking milk to avoid symptoms. Okay, go to that. And I'm back. So I didn't want to, it seems we went several pages ahead, so I apologize for that. And, you know, I get a little excited. All right. So causes of diarrhea, many things. It could be food, allergies, infections, diverticulosis, which we're going to talk about in a bit, malabsorption, where it just kind of goes through the patient, then they're really not absorbing their vitamins. Cancer can cause diarrhea, stress, fecal impactions. So even though they have an impaction, the liquid stool can go around that impaction and they still present with diarrhea, even though they have an impaction. Sometimes tube feedings can give diarrhea, and that can be part of your malabsorption or your, what's the word I'm looking for? You're not here to help me. Anyway. Complications, it can cause a threat when patients, dumping syndrome. There we go, I thought of it. Okay, complications. It can cause a threat when patients become dehydrated. So that's important to know. Diarrhea can make you dehydrated. And what are the signs and symptoms of dehydration? You're going to get a low blood pressure, your heart rate's going to be up, trying to pump blood and your fluid to the rest of your body. Might get sweaty, especially the very young and very old are very sensitive to this. It can cause electrolyte imbalances and metabolic acidosis. If chronic, can also interfere with absorption and nutrients and can lead to malabsorption and anemia. And that points us to page 746. So treatment is usually resting the GI tract and giving anti-diarrheal drugs. Remember those anti-diarrheal say that 10 times. Antidiarrheal drugs was back in our introduction to the GI system. There's some antidiarrheal drugs there. A lot of times they'll dry the mouth out, even more so than the patient may feel already dried out. But it helps slow the mo. That's what I like to call it, because it's medication that slows the motion of the GI tract. Sometimes a clear diet is also recommended for outpatients. Many inpatients are placed on NPO status and given IV fluids to replace that dehydration, that hypovolemia type of symptom. All right, so our interventions, of course, we just mentioned the fluids and nutrition. We want to be sure they get good nutrition. Daily fluid intake, 2 to 3 liters or 2,000 to 3,000 mLs. Hope you're still with me on page 747. Pain, they might have some cramping with that diarrhea, and antidiarrheal drugs can help with that. Disrupted skin integrity, so like I said, their rectum might be really sore and raw from wiping with tissues, so they'll need some lubrication, maybe some anti-hemorrhoid, which they probably have hemorrhoids with the diarrhea because of just it pours out and it's so irritating. Some wipes contain steroid or some aloe, some calming anti-inflammatory agent that they can apply to the rectal area. All right. Inability to use toilet independently. Well, they may not be able to get there fast enough, especially the elderly. They can't get out of bed, and they're probably weak from having diarrhea anyway, and then they've got an IV. So you might have to help them back to bed. All right. Now we can go to the next slide, which is just the opposite, constipation. So constipation is on page 747 in your book. The frequency of defecation varies among healthy people. Bowel movements may occur as often as 2 or 3 times daily or once a week. So it depends. Everybody's different, but I will tell you this, that most elder people are very obsessed with their bowels. They think they should go once a day. It's not necessarily true for everyone, but they think it is. So they may keep wanting to get up and go to the bathroom because they think they should. And if they do have the urge, they should get up, because if you have an urge to defecate, you need to get up and go right then, because that urge might go away if you don't. All right. So ignoring the urge to defecate when it occurs can be a cause of constipation. Frequent use of laxatives or enemas may contribute to chronic constipation. That sounds counterintuitive, doesn't it? Overuse of laxatives, but because they get rid of so much when they go to the bathroom, there isn't anything left, but they think that they need to go. Or their nerves and muscles are so desensitized to having to go to the bathroom because they've been given this false medication that makes them go, then they don't really know what it feels like when there's actually stool in the rectum. Waiting. It's like waiting to go. Inactivity is another cause of constipation, so being sluggish or sedentary. Inadequate water intake can be a cause of constipation, and there are some medications that can lead to constipation. I can think of one offhand, and that's pain medication. That can be constipating. It slows the bowel integrity. You just don't have the urge. You just don't have the motility to go. So complications of constipation would be the Valsalva maneuver or the vasovagal reflex. What that is, so it's the straining. So you're straining to go to the bathroom. You're trying to strain it out. And this is what I call the Elvis Presley maneuver, because he died on the toilet and he was taking pain medication, lots of it, and he probably had to have a bowel movement because he was sitting on the toilet, and he probably vasovagaled, and what that means is he slowed his heart rate down. Now his heart probably wasn't in great shape because he was overweight, so he probably slowed his heart rate down, had a heart attack, and died. That's what they say. It's one of the rumors about it. It's an easy way to remember. It can cause hemorrhoids, that constipation. It can also cause fecal impaction. So treatment is prompt initial results using laxatives, enemas, or suppositories. A combo of these. In the future, they need stool softeners, a diet change, and that diet change might mean fiber. Fiber is really important in the lower GI tract because it keeps the colon stimulated to go to the restroom, and hydration. So it keeps the stool from being hard, so they don't have to bear down and try to go to the bathroom. So hydration. All right. Talked about the complications. I'm over on page 748 now. We talked about the medical treatment, your focused assessment. Just remember, check the abdomen for distension or peristalsis, and that is that movement of the colon muscles. That if we had a visual, I'd show you. It's kind of like a squeezing motion that the colon moves the stool along to go to the bathroom. We can palpate the abdomen. I've palpated an abdomen and actually felt like it wasn't a mass, like a tumor, but it was stool. So they developed a mass of stool in their colon, and it was painful when I touched it too. So something that you might feel or see when you are examining your patients, doing your assessment. So look at the patient teaching box for constipation, high fiber foods. So that's really important in many of these things we're going to be talking about in the colon. Drink 6 to 8 glasses of water. So fluids important, exercise important, going to the bathroom when you have the urge is important. You don't have to have a bowel movement every day. A lot of elderly people think you do. I know this is repetition, but I just want to be sure we get everything. Megacolon, haven't talked about that. So what is that? You might hear it. Megacolon is a condition in which the large intestine loses ability to contract effectively. So it's not doing the peristalsis. So it's large. A lot of, when they do colonoscopies, some patients have megacolon. It's just a big old floppy colon. It doesn't move real well. Fecal impaction, always have to be aware of that and watch for that in our patients. You can check for that with a lubricated finger in the rectum, and you might feel it right there in the rectum. Sometimes they have to be disimpacted, which would mean that you remove those little pebble stones of stool. But you have to be really careful because, you know, you could do that vagal stimulation. So in the elderly, they're very sensitive. So be careful when you do that. All right. In the book, it says the procedure of disimpaction is painful and embarrassing for the patient. But I'll tell you, I've disimpacted a few patients after heart surgery, and they loved me because it made them feel so much better. So they can really love you after you make them feel better. So stool softeners, diet changes, hydration. Let's change the subject. Intestinal obstruction. So causes of intestinal obstruction can be many, They can be strangulated hernia, a tumor, paralytic ileus. What that means is it's not moving. The colon isn't moving. It's like paralyzed ileus, stricture. A stricture is a narrowing. So we've got a paralyzed ileum, we've got a stricture, a narrowing, we've got a volvulus, which is a twisting of the bowel, and there's a good picture of that on the slide here. It's also in your book on page 750. It shows hernia, intussusception, and volvulus. The intussusception is a telescoping of the bowel into itself, and you can see that on page 750 as well as here on the slide. When the bowel is obstructed, digestive contents cannot pass, and that's a problem, isn't it? So I'll tell you, people with intestinal obstructions are in a lot of pain. They can be hospitalized for an obstruction. They'd be on IV fluids for quite a while sometimes, and they're in a lot of pain. So I've seen them in the hospital 2-3 weeks on IV fluids, waiting for their bowel to start working again. Signs and symptoms. Vomiting can be a symptom, and I've even seen them vomit stool contents because there's been an obstruction lower, and they might be vomiting up not just bile, but even if it's lower, they're gonna, all the things are gonna back up from the obstruction, and they might vomit that up. So they might even have to have an NG tube to suction that out, especially if it's stool, right? Don't want that in the mouth. And that would be attached to suction, IV fluids, and sometimes they may need a surgery. Now, they do try not to do surgery, so they try to keep them in the hospital, keep them hydrated, try to get that colon working on its own to avoid surgery, but sometimes you have to have it. So if we'll turn over to page 750, so that is your pictures you can see there. Also, patient problems, goals, and outcome criteria. So patient's problems, pain related to distension. So you want to give them pain relief, and believe me, they're in a lot of pain. Fluid volume deficit they are in, related to vomiting and intestinal suction. So you're going to need some hydration, and monitor their pulse and blood pressure. And their mucous membranes, are they dry? You want to try to keep them moist. Equal I and O. Potential for infection, we want an absence of infection, so we're going to monitor their blood. Check for a white count. Is it high? That usually means infection or inflammation. Inadequate oxygen related to abdominal distension, so if their belly's big and bloated, that may constrict their lungs from expanding, and also they're on bed rest because they're in so much pain. So we want them to breathe, be sure their respiratory rate's within a normal rate, follow their vital signs. They're going to be very anxious related to the pain, and if they're in the hospital for a long time, that makes them anxious too. When am I ever going to go home? When is this ever going to stop? Right? So how do we know when this is over? Well, we might hear bowel sounds, because when they've got an obstruction, there's no bowel sounds. Or they might have bowel sounds maybe in 2 sides, but not the other 2 sides. It depends on where the obstruction is. You might want to even measure their abdomen to see if it's large or if it's getting smaller. You know, maybe the obstruction is being decreased. But another way that we know an intestinal obstruction is over is their vital signs return to normal. They've got a normal blood pressure, heart rate, temperature. They're all normal, within normal range. Another way we know intestinal obstruction is over, mucous membranes are moist. They're not dry. Their intake equals their output. So their I and O is equal. So those are some really important things to remember about how do we know when intestinal obstruction is over. All those things we've been taking care of all along, right? They're all gone. So vital signs normal, mucous membranes moist, and their I and O is equal. Okay, let's move on. Appendicitis. Well, you know, back in the old days, people died of this because they had no way of knowing really what it was. So appendicitis is an inflammation of the appendix. We don't really need the appendix anymore. Rumor is they say appendix was like for meat eaters, like back in the caveman days, but we still have the appendix. Maybe it was larger then. Now it's a small, just appendage. It's in the right lower quadrant of the abdomen, right where the small intestine meets the large intestine. That's where the appendix hangs out, literally. So inflammation occurs when the opening of the appendix to the large intestine is blocked. This can lead to a ruptured appendix. Now that can be really bad. So a ruptured appendix allows digestive contents to enter the abdominal cavity, causing peritonitis. So you've got stool contents emptying into the abdomen. So peritonitis, painful, could be sudden, like if it's a sudden rupture, sudden pain. It can be life-threatening because they're going to immediately get septic with all those stool contents going into the abdomen. It's a surgical emergency. It's also a sepsis emergency. They might need antibiotics. When they open the patient up, they're going to wash that abdomen out with normal saline and possible antibiotics to help get rid of the possibility of infection. So early detection of appendicitis permits treatment before the appendix ruptures. So what are the signs of appendicitis? So I want you to go to signs and symptoms there on page 751. So the biggest one is McBurney's point, and you can see this on the picture here, McBurney's point. It's kind of up above the appendix. It's not over the appendix, it's above, a little below the umbilicus. So if you push on McBurney's point, they get pain in their appendix. So it's very interesting and a definite sign of appendicitis. All right, so medical treatment, if it's suspected, appendicitis is suspected, the patient's placed on MPO, cold pack to the abdomen. If the appendix is inflamed, heat or laxatives can cause it to rupture. So cold always takes the discomfort away. All right, you can look at the nursing care here of the patient with appendicitis. So record allergies, medications, I&O, and notice the patient problems, goals, and outcome criteria to appendicitis, potential for infection or peritonitis. Really good word to know, important word to know. One of the signs of peritonitis, not only a tender abdomen, but a rigid abdomen. So their abdomen is like a drum. I mean, it's hard like a drum. And that's called a rigid abdomen, very painful, indicative of peritonitis. Nausea and vomiting they might have, fever they might have. I'm going to turn the page here, 752. Pre-op intervention, so you want to keep that patient NPO. Now, a position that's pretty comfortable for a lot of colon situations is side lying. So an appendicitis side lying position with hips flexed is more comfortable. When they straighten out their leg, it hurts more. Post-op interventions. So important thing to remember anytime you have surgery, but I'm going to talk about it here after appendix and you've got a surgery. You can have the incision can go straight across from ilium to ilium, side to side. kind of like a happy face type. If it hasn't ruptured, they can do it through the umbilicus. So exploratory laparoscopy, appendix removal. But however they do it, their abdomen's going to be sore. If they've had inflammation there, it's really going to be sore. But we still have to have them cough and deep breathe so that they don't get pneumonia, an HAI, a hospital-acquired secondary to appendicitis. So show the patient, now this is on page 752, show the patient how to splint the incision during deep breathing using a pillow or blanket. So that's pretty important there. Splinting for surgery. Okay, let's move to peritonitis. I was just talking about it. So the interesting thing about the peritoneum, before I get into this, it has blood vessels, lymph nodes, nerves. It has two layers, a parietal and a visceral layer, with a space between them that's serous membrane. So it's a membrane that kind of lays over all the organs. It's protection of our organs, but it can get inflamed. And it can be from a rupture in the digestive tract, including appendicitis, bacterial contamination. Sometimes peritoneal dialysis can do it. Fallopian tubes or non-sterile traumatic wounds can cause peritonitis. So again, inflammation of the peritoneum, which is the shock absorber. Chemical contamination may follow rupture of a digestive tract stricture. Bacterial contamination may be caused by a rupture of digestive tract structure or fallopian tube. I know, I said that. So you want to be sure to treat them for pain. So I'm following along over here on page 753 now. Pain medication, decreased cardiac output because of the fluid shifts. They might be hypovolemic, so we got to keep track of their I and O. Inadequate nutrition, GI decompression usually eliminates nausea and vomiting, but they might need that NG tube. Depends the problem. The patient's very anxious. They just suffered a lot of pain also. So be sure that you give simple explanations for procedures. So explain what's going on, but be very simple and to the point. Knowledge is power. We want them to know what's going on. We don't want to scare them. We just want to be simple and plain in our descriptions. And encourage the patient to ask questions. We also want them to know the importance of breathing and leg exercises. And they might be on IV antibiotics. So they'll have an IV. Now let's talk about abdominal hernia. It's a weakness in the abdominal muscles that keep our organs in place. Oh, they're kind of pushed aside, and a portion of the large intestine pushes through the abdominal wall. Now, after my C-section, I had a hernia just because of the weakened wall. So that was in an unusual place, kind of right next to the incision. But the most common places is the umbilical hernia. So it pushes out in the umbilicus. Maybe when they lie flat, it goes away. But when they cough or get up, it may bulge out. Incisional hernia, that's what I had. It's kind of off to the side. There's also inguinal hernias, which is there's a little inguinal canal in the, right where the hips flex there. That's the inguinal area. You can have an inguinal hernia there. Sometimes little babies are even born with that. When they're diagnosed, it can be treated if it's not painful, but there is a risk that it can twist. So when it's convenient, they like to try to repair that, especially if it's big. The lump may disappear when the patient lies down. or at rest, but returns when standing or straining. Now, you know, weightlifters, they wear a special belt when they lift weights because they can develop a hernia from lifting heavy weights up above their head. So they wear a heavy belt to prevent hernias. And then incarceration is where the hernia twists, and that's an emergency, and that's severe abdominal pain. And you can read the medical treatment. Some patients can't tolerate the stress of surgical hernia repair, so they use a truss, which is like a belt. They're not used widely, but it consists of a pad that's placed over the hernia and a belt that holds it in place. So you can see under the patient teaching for a truss, put it on first thing in the morning before they rise up, so they keep that abdomen or the bulge in. Check under the belt and pad several times a day for any irritation. It doesn't cure the hernia, so they need to avoid straining. If you look at the nursing care, just real quick, I want to talk about a focal assessment. So what does a focal assessment mean? That means that here we are with an abdominal hernia. So we're going to look at the abdomen. That's a focal assessment. So the most relevant aspect of the physical exam is the assessment of the abdomen. And I want you to know that that's called focal assessment. If they had respiratory problems, your focal assessment would focus on the lungs. So you can read through here the patient problems, goals, and criteria after a hernia. Pre-op interventions, of course, knowledge is power. Monitor the patient for signs and symptoms of strangulation because it's a real emergency. And that would be nausea, vomiting, pain, abdominal distension, fever, tachycardia. That's at the bottom of page 754. And then you can look at the patient problems, goals, and outcome criteria after a hernia repair. A unique thing about post-op, though, and this is on page 755, is urinary retention. So many patients have temporary problems with urination after hernia repair surgery. So keep I&O records, document voiding, and palpate for bladder distension. Same goes for constipation. So they're at risk for constipation. They will have pain and potential for injuries. So a lot of times activities are restricted for 2 to 6 weeks after surgery. So let's move on to inflammatory bowel disease. Now IBD, inflammatory bowel disease, refers to ulcerative colitis and Crohn's. They're two different things. Crohn's disease is also known as regional enteritis. With ulcerative colitis, the inflammation typically begins in the rectum and extends up the bowel towards the cecum. Now, the progression of Crohn's disease is different in that it can be anywhere. Most commonly found in the ileocecal area. In fact, when a doctor does a colonoscopy, he'll need to go all the way to the ileocecal valve and try to cross that to the small intestines. That's definitely indicative of Crohn's disease, but it can be found anywhere, especially when it gets really, really bad. So exact cause of IBD is unknown. Possible causes could be infectious agents, autoimmune, can run in the family, allergies, foreign substances. So signs and symptoms. So when ulcerative colitis affects only the rectum, the patient may be constipated. More commonly, the patients have diarrhea with frequent bloody stools. And that's pretty common for both of these diseases, frequent bloody stools, so they might need, definitely need labs, H&H, to follow to see if they're anemic. They might need units of blood to be administered. and they might be in the hospital because of those frequent bloody stools. So not only are they anemic, but they're dehydrated. So they might need IV fluids as well. Hope this is kind of making sense so that you can kind of picture each thing, what it causes, what can be the complications, because it's a concept of when you've got diarrhea or something that causes a lot of fluid to be lost, whether blood, diarrhea, you're going to get dehydrated and you could get hypovolemic. So those concepts, what is your heart rate going to do? It's going to go up because you're at risk of low volume, and your heart's trying to compensate for a loss of volume by pumping faster to get fluid or blood to all the organs. So symptoms of Crohn's disease are even more variable because it affects different areas. It can affect the stomach, it can affect the duodenum. Symptoms would be nausea, vomiting, epigastric pain, and they also can have bloody stools. Now I know, let me just look here, I'm on page 756, looking at treatment, medical treatment. Steroids can be a treatment because it's an inflammatory condition. So steroids are used for inflammatory conditions. Also, immunosuppressant agents suppress the immune system. Antidiarrheals to control the diarrhea. Anticholinergics, that slows the mo also. Antibiotics, they might need to treat attacks of Crohn's disease. Also the next one, aminosalicylates. It's called 5-ASA. So that's kind of a short term for aminosalicylates. It's mesalamine, and they can be given oral, suppository, or an enema to reduce symptoms. And a lot of patients with Crohn's disease will be on multiple medications. Another medication that's given is Remicade, that blocks the inflammatory process in Crohn's disease if they don't respond to other drugs. Patients with ulcerative colitis are maintained between acute episodes with aminosalicylates. The 6-MP is usually more appropriate for Crohn's. Now, what's really important here to know is that, and this is on page 756, and it's a low roughage diet. Without milk products, it prescribed for mild to moderate IBD. So we don't want any more inflammation with roughage. I know I talked about how important roughage is in most of the conditions. In this one, low roughage diet, because they're already irritated. So low roughage diet without milk products. They might need IV fluids, even TPN might be needed to provide fluid, electrolytes, and nutrients. Now, if all else fails, they might need surgery. So that would be removal of some of the colon, especially the inflamed part of the colon. That's a colectomy, and that's curative for ulcerative colitis. But I'll stick with this for a second. So the opening, they might, if they take out part of the colon, they might need an ileostomy put in. That eliminates the digestive waste. Now, surgical treatment of Crohn's disease is more likely to involve removal of diseased portion of the colon. But they don't like to do surgery for Crohn's disease because recurrence is so common and it goes all different places. So if you keep cutting out Crohn's disease, you're going to be cutting out all kinds of part of the body. So they try not to do surgery. They try to keep it under control as much as they can with medication. So only if it's absolutely necessary. And then I just want you to read that pharmacologic capsule there where corticosteroids, this is another concept that you need to know. So corticosteroids are anti-inflammatory, but they also suppress the immune system and inflammatory responses. So the patient is more susceptible to infection. So steroids are good, but they can be risky. So that's a good thing to know. Right, you can read through nursing care of the patient with the bowel, IBD, focused assessment. Of course, we're always going to look at the abdomen, INO, vital signs, maybe some blood tests. If they're in pain, we want to take care of that. But so one of the risks is dehydration. And if they've lost a lot of blood, they're going to be fatigued. So in the patient problems, goals, and outcome on page 756, it talks about fluid volume deficit related to diarrhea. Well, yeah, they might have that. And with that comes dehydration, which is why we're going to have to give IV fluids. But they might come into you before they've got treated with dehydration, and because of bloody stools, fatigue. Also, being dehydrated makes you pretty tired also, if you've ever had that on. All right, so you can read through the patient teaching, inflammatory bowel disease, important. I see here, you can facilitate digestion by taking small bites, eating slowly, and chewing well. That's a common theme, isn't it? Concept. All right. So remember, they are at risk for fluid volume deficit because of severe diarrhea. So we want to keep an eye on that. Always assess their fluid status by checking their mucous membranes, tenting, hypotension, tachycardia, decreased urine output. There's another concept. So we have, whenever we have hypovolemia or hypotension, we're going to have tachycardia, increased urine output. Decreased urine output. So IV fluids and maybe TPN would be administered. Inadequate nutrition, inadequate coping. It's rough, when you keep having these remissions and one day you're good, another day you're bad, and one day you can go out with your friends and another day you can't, and it's kind of an up and down. It can ruin your social life. It can really get you down. So inadequate coping is definitely a problem with IBD. Potential for injury, yeah, if they get dehydrated or medication makes them immunosuppressed. Okay, I think we've talked enough about that, don't you? Let's move on. This is getting to be a long lecture. Diverticulosis. Well, this is an interesting subject, one of my favorites. So diverticulosis is a condition characterized by small sac-like pouches. This picture is great. It shows you the little pouches called diverticula. And diverticula occurs when weak areas of the intestinal wall allow segments of the mucous membrane to herniate outward. So they make little pouches. Well, where are they found? Where are they found? Most diverticula are found in the sigmoid colon, and usually more than one exists. So I'm going to be talking about that a lot. Diverticula can cause a problem when stool or food or seeds get stuck in the pouches, and then it causes diverticulitis. So that's a problem. So I want you to remember under risk factors on page 757, because diverticulosis is most common in developed countries, it's thought that lack of dietary residue. So poor diet, right? Low roughage can cause this problem. So that's important to know, that roughage will help control diverticulosis. It keeps the bowel moving so that you don't get food stuck into the pouches. Make sense? Other factors, I'm turning the page now to page 758. It's a really good picture of the diverticula in the sigmoid colon. Now, the sigmoid colon is the most common place for colon cancer, and we'll be talking about that. But I just kind of want to relate it to, we're talking about the sigmoid colon. A lot can happen there. It's on the left side of the abdomen. You can get diverticula there. You can get colon cancer there. We can get IBD there. So lots can happen there. Other related factors to this diverticula: age, constipation, obesity, and emotional tension. And that emotional tension, you get all stressed out, you don't go to the bathroom, but take a drink of water. All right, thank you. Most diverticulosis is asymptomatic, but they might report a change in bowel habits. Now that's a diagnosis that a doctor would use that would be acceptable by Medicare to do a colonoscopy. Change in bowel habits, because it can be a sign of colon cancer. So change in bowel habits is important to mention. And that's something that you ask, right? When you do your head to toe, have you moved your bowels? Have you had any change in your bowel habits? Is it liquid? Is it, I can go on. And you can too with your patients. All right. So I want to get over to, so we talk about signs and symptoms, right? Constipation, diarrhea, might have both, either one. Complications, the diverticulitis is a complication that may require even antibiotics. They might have a fever from it even. Usually the diagnosis is based on the symptoms. The stool is tested for occult blood. They could have a CT scan that might show, or a barium enema even. But let's look at medical treatment. So diverticulosis is treated with a high residue diet. So fiber, without spicy foods. Stool softeners or bulk-forming laxatives are used to treat constipation, and anti-diarrhea agents are prescribed for those who have diarrhea. But the treatment for diverticulosis is high residue, lots of bulk, lots of fiber, even extra fiber. You know, if a if a patient can't get enough fiber in their diet, you can buy Benefiber. You can buy fiber pills, FiberCon, that gives them extra fiber, and they don't even realize it. I mean, that Benefiber can be dissolved in a cup of coffee, and they're getting extra fiber, and it's added in their coffee. They don't even, and they'll gladly drink their coffee, right? All right. Nursing care, just take a peek of that. Another thing under diverticulosis that's important to know is, okay, so you've got these pouches, right? Maybe something goes in them. You've got diverticulitis now. Well, what happens if one ruptures because it gets so full of stool or food or something and it ruptures? So at the top of page 759, it says, be alert for signs of perforation of one of those diverticuli. And that's an opening from the stool to the outside, so then they can get peritonitis too. But the signs and symptoms of a perforation would be fever, abdominal distension, rigidity, their abdomen's hard and painful, and they are very uncomfortable. All right, they might even need surgery. It might need part of that colon cut out. All right, we're going to talk about colon cancer, and this is kind of a segue into that. So diverticuli are not the same as polyps. So I want you to know that. Polyps go inward, and it's like a little mushroom growing inside the colon. These are diverticuli that are pouches on the outside of the colon. They go to the outside of the colon. So I want you to be clear on that. Colorectal cancer. It's the third most common cancer of men and women. It can tend to run in the family. People at great risk for colorectal cancer are those with histories of irritable bowel disease because of that constant inflammation, family history of colorectal cancers, or multiple intestinal polyps. So that was my segue into the polyps. So if you look over on page 759, signs and symptoms, it can be weakness, fatigue related to blood loss, and is the early symptom of right-sided colon cancer. Now, most colon cancers are on the left, the sigmoid colon. That's the most common side. Also, a change in bowel habits, blood in the stool. Stools can become very narrow. Maybe they get a tumor in their colon, so their stools become kind of ribbon-like, pencil-like. So let's go down to medical and surgical treatments. All right, colorectal cancers are usually treated surgically. So if there's a tumor, if there's a cancer, it needs to be removed. The exact surgical procedure depends on the location and extent of the cancers. For cancers above the rectum, the diseased portion of the intestine can often be removed. Rectal cancers often require more extensive surgery. So this is important to know here, and it's in page 759 under medical and surgical treatments of the colorectal cancer. And it starts out, this paragraph, rectal cancers often require more extensive surgery with incisions in the, number one, abdomen, count with me, abdomen, perineum, and they might have a colostomy. So they actually have 3 openings that they're going to have 3 incisions from the surgery. It's pretty extensive. So they call this an abdominal perineal resection with colostomy. So those 3 things, with the abdominal perineal resection and colostomy, 3 incisions. So they need the colostomy for removal of, obviously, the stool. Nursing care, so you've got a double whammy here. You've got not only a surgical patient you have to take care of, right? So the coughing, the breathing, prevention of pneumonia, getting them up and moving around. But they also have that component of they have cancer. So you're going to have to deal with them for inadequate coping because they have a life-threatening illness. But you've got to get them up. You've got to get them moving around. They might not want to. They're going to be depressed, and it hurts. So it's very important that you get them up and move them around, just with any intestinal surgery. But this one has another component in it. It might have a colostomy also. They've got the depression angle. So they're also going to be, let's turn the page to 760. They might have drains and packing in all their wounds. So be sure that you check their incision, the drainage, the color, not just the color of the drainage, but the color of the incision. What does the incision look like? And how does the wound look? Is it closed? Is it open? Is it dehiscing? Is it, are the sutures look red? So a lot of description in the incision. And they might have some drainage, like Jackson Pratt drains. And remember, whenever they have a drain, a Jackson Pratt's like a bulb type of drain. You would have to empty that out, and that would count as output. And the way that works is it fills up with fluid, right? And you empty it, and then you squeeze it and put the lid on it, because that suction is what helps pull out that extra drainage during and after incision, after surgery. Sorry. All right. So they might have a binder to hold all their dressing in place. It's going to be uncomfortable. You've got to get them up. You've got to look at their incision. You've got to look at their wound. You've got to look at their drainage. So there's a lot to take care of. And you've got to take care of their mind. And you have to take care of their pain. So go down to pain on page 760. Pain is severe for several post-op days. So be sure you give the opioid analgesics as ordered. And if they don't get relief, call the doctor, and they might need something more. So at first, the patient will probably be most comfortable in a side-lying position. That was similar with the appendicitis. Remember that? So side-lying, they're going to be more comfortable that way. They might be comfortable with a pillow under their abdomen supporting that incision. So we want to be sure that they're comfortable, pain relief, but we've got to get them up too. So under patient teaching, under colorectal cancer, I want you to read through that. Wound care, colostomy care if that's needed. Their diet should be high in fiber. Medications. If there's any signs of inflammation, be sure that, and the patient teaching is usually when they go home, right? But you and them both, when they're in the hospital and when they go home, any redness or any kinds of problems or even inability to go to the bathroom, maybe something's happened in the surgery, or maybe their tumors come back, or could be all kinds of reasons. Okay. Let's go on from this because I want to talk about polyps. All right. So what are polyps? These are the mushroom type things that are inside the colon. Patients have colonoscopies with polypectomy, removal of those growths in the intestine. Some are benign, but they can become malignant. That's why it's important that patients have colonoscopies, and if they have a history or family history of polyps, they need a colonoscopy so that those polyps are looked at. Interesting here, inherited syndromes. So there's something called familial polyposis, and what that means is that it runs in the family, and they have multiple polyps. And I'm not telling you it's 10, 20, 25, 30 polyps, a lot of polyps. If a patient has a familial polyposis, the doctor may not remove them all at the same time. It's just too much work, and it's too dangerous to the patient because they can cut them out or they can burn them off. Some might have to go to the lab to be sure that they're benign and not malignant. But familial polyposis a lot of times can turn into cancer. Now the Gardner syndrome, that is multiple polyps also. It's even more polyps than the familial polyposis. So that's kind of the difference. Also in the Gardner syndrome, they tend to get cancer sooner at an earlier age than someone with familial polyposis. Just want you to know the kind of difference there. But polyps, important, whether it's 1 or 2 or 20, right? They're usually asymptomatic and found on routine testing, but that being said, they can bleed also, and that could be the occult blood. You don't even know that it's bleeding. That's a sign sometimes of polyps or colon cancer even. Complications are bleeding and obstruction with polyps. Polyps can get so big that they obstruct the colon. It's usually diagnosed by barium enema or more commonly endoscopic exam. They can do a flex sigmoidoscopy. That's just where they go on the left side of the colon. That's a flexible sigmoidoscopy, but a colonoscopy will go the whole length of the colon up, across, and down the colon. Colectomy for familial polyposis. So if they keep getting a lot of polyps, and that because of the risk of cancer that goes along with the Gardner syndrome, they might need just that colon taken out, okay, because of the risk. All right, so let's move on. Hemorrhoids. So they may be above the sphincter muscle of the anus. So you can have internal hemorrhoids and external hemorrhoids. External hemorrhoids are more visible. Internal hemorrhoids, you can't see them. They're above the sphincter muscle of the anus. They're dilated veins in the rectum. They may be above the sphincter muscles, as I was saying, internal hemorrhoids or external hemorrhoids. And there is a great picture, figure 39.7 on page 761 of hemorrhoids. We know that they're uncomfortable, painful. Hemorrhoids contain clotted blood, are said to be thrombosed. So thrombosed hemorrhoids might have to be removed. So there's nursing care of the patient with hemorrhoids. And of course, let's look at the patient teaching box on page 762. If you'll do that for me. That's post-op care. So they had to have hemorrhoids removed. Let's say they had a hemorrhoidectomy. So notify your surgeon if you have fever or bleeding. Prevent recurrence, avoid constipation. Prolonged sitting or standing. You know, a lot of people like to sit on the toilet and read a magazine. Not a good idea. That leads to hemorrhoids. Because think about that toilet seat kind of, you know, going around the buttocks area, and it allows for pressure on the hemorrhoid area, on the anal area. So they shouldn't sit on the pot for too long. Sorry, on the toilet. Also, under this post-op care of hemorrhoids, I want you to notice, ingest a high-fiber diet with plenty of fluids to promote regular soft stools. So, soft stools, high-fiber diet, plenty of fluids. We want that for our hemorrhoidectomy patients, because if it's hard stool coming out, it hurts the hemorrhoids. So we want it to be soft. Okay, let's go to the next one and talk about an anorectal abscess. So it's an infection in the tissue around the rectum. Signs and symptoms are rectal pain, swelling, redness and tenderness. It can be treated with antibiotics, followed by incision and drainage, or IND. It's called because this is an abscess. So they're going to have to cut it open and drain it. So pre-op, the pain is treated with ice packs, sitz baths, and topical agents as ordered. So you can just read through that on page 762. Of course, thorough cleaning. This is an abscess and this is a dirty area. So the sitz baths really help the discomfort, as well as keeps it clean, keeps that area clean. So they want to be sure and keep their area clean. Their private area. All right, anal fissure. So what is a fissure? Well, it's like a laceration. So an anal fissure is a laceration between the anal canal and the perianal skin. It can be related to constipation, diarrhea, Crohn's disease. Crohn's disease a lot of patients get anal fissures. TB, leukemia, trauma or childbirth. Sometimes there's not even a reason. They just get them. So you can read through that anal fissure area. Conservative treatment, sitz baths, stool softeners, and analgesics. Surgical incision may be necessary. Anal fistula. So an anal fistula is an abnormal opening between the anal canal and the perianal skin. Now you can have fistulas anywhere. Fistula means an opening. This one happens to be anal fistula. So if you hear that word fistula, it's an abnormal opening. It can be for dialysis. I know that's kind of a weird way to put it here in the anal fistula, but I just want you to realize that word fistula means artificial opening, whether it be for dialysis, whether it be some patients I've had fistulas from the colon to the bladder. So it's an abnormal opening. They can occur anywhere. This one, between the anal canal and perianal skin, develops from anorectal abscesses or related IBD or TB. Patient typically complains of pruritus and discharge. Sitz baths provide some comfort. Surgical treatment is excision of the fistula and surrounding tissue. Sometimes a temporary colostomy to allow the surgical site to heal. That's a temporary colostomy. So it can be reversed. It doesn't have to be permanent. This is just to give that area a rest. Post-op care, analgesics, sitz baths for pain. So last but not least, let's talk about pilonidal cysts. So it's important to know where these are located. If you haven't heard of it, it is not uncommon. I've heard rumors that that was a twin that was attached to the sacral area. So know that it's located in the sacrococcygeal area. Very important to know. It's the very first statement under pilonidal cyst. Pilonidal cyst located in the sacrococcygeal area. It results from an infolding of skin causing a sinus, meaning an opening, that is easily infected because of its closeness to the anus. I actually had a student once that had a pilonidal cyst, and I mean, he was a big guy, weightlifter type, big football player guy. He got a pilonidal cyst. You would have thought he was a little girl because it was so painful. That's not an insult. What that means is that it was so painful that he had to sit in the back of the class. Now, bless his heart, he came to class every day. He was scheduled for surgery on a weekend. But until that surgery, he was in such pain, he sat on a pillow in the back of the class and had to keep changing positions because it was so painful. So once it's infected, it's painful and swollen and can form an abscess, needs surgery. Care is similar to that for the patient having a hemorrhoidectomy. So just remember where a pilonidal cyst is located, the sacrococcygeal area. That's like right at the top of the crack of your buttocks, or right there in the sacrum. I wish you could see where I was pointing, but just kind of pat the back of your bottom, and that's right where it is, right at the base of the spine too. All right, well, thank you. Sorry I kept you so long. I know that was a long lecture. Thank you. Okay, sorry, push the button. Patient education to promote normal bowel function. So good hand washing and proper food handling. People who recognize that stress affects their GI tract may benefit from relaxation techniques and stress management training. I have a great relaxation tape that I listen to at night. Helps me go to sleep. It's more of a meditation tape, but they have really good ones out now. Or maybe just listening to nice soft music is a good way to relax. Signs and symptoms of digestive problems should be reported for prompt diagnosis and treatment if it's indicated. Also, teaching patients what is normal, how to promote normal function, and how to detect problems can help to avoid serious GI dysfunction. So we know we need fluids, we know we need fiber, very important to keep our GI tract healthy. So keep yours healthy.